A very happy morning to you all. On behalf of Department of Pediatric and Preventive Dentistry, KSR Institute of Dental Science and Research, Tiruchengodu, Tamil Nadu, we welcome you all for the second day of our CDE program, the Open Secret Pedo Aesthetics. We are glad that we are conducting the CDE program under the aegis of our Indian Society of Periodontics and Preventive Dentistry. And hope the secrets you have learned yesterday will help you all to improve your practice. And we have some more secrets to be learned. And today we have three speakers, Dr. Ganesh Jeevanandan, Dr. Milind Shah, Dr. Abhishek Soni. They are here to share their knowledge and their clinical secrets in restoring the pedo aesthetics. So my hearty welcome to all the resource faculties, and we are very happy to have you all. And I request all the participants to attend the pre-test and post-test for your e-certificates. And now I request Dr. Yogesh, Reader, Department of Pediatric and Preventive Dentistry, KSRIDSR, to introduce the first speaker of today, Dr. Ganesh Jeevanandan.
Thank you, ma'am. Good morning, one and all. Today's first speaker is Dr. Ganesh Jeevanandan, who has completed his undergraduation and post-graduation from Meenakshi Dental College and his PhD from Savita Institute of Medical Sciences. He has received a gold medal in the specialty of Pediatric and Preventive Dentistry at Chennai. He is also the inventor of Pedo, which is an exclusive pediatric rotary file, for which he has been given the International Innovation Award at London. He has also been given the Best Clinician Award, the Master of Periodontics at International Conference of Case Reports and Reviews. He has given guest lectures at various dental colleges throughout the country, and he also has around 35 publications, national and international publications, to his credit. Currently, he is working as an associate professor in Savita Dental College, Chennai, and also holds the position of Assistant Dean of Innovation and Development. Today, Dr. Ganesh will be sharing his knowledge about the use of Figaro crowns in pediatric dentistry. Thank you.
Yeah, can I share my slide?
Yes, Ganesh, you can share. I've made you a co-host. You can share.
Yes. So the audible is visible, sir. Can you all hear me?
Yes, Ganesh, it's clear and we can hear you.
We are ready to go. Okay, very good morning to one and all present here. This is Dr. Ganesh Jeevanandan. First of all, I would like to thank KSRIDSR sir for giving me this opportunity to talk about Figaro crowns. I personally feel this particular topic is to be discussed because there are a lot of people who call me and ask, sir, what is this Figaro crown? What is it about? Whether it is working or it is not working, whether it is available in market or it's not available in market. Give us some information about this particular Figaro crown. So I currently work in this particular college, Savita Dental College in hospitals. So my presentation is very simple and I've kept it very easy for you to understand what exactly happens with this particular thing. So why this particular crowns? If you ask me, crowns in pediatric dentistry, do we have to discuss so much about pediatric crowns, or we have to know about all these crowns available in market? Yes, what I strongly believe is over a period of time, not only in pediatric dentistry, all about general dentistry also, there are a lot of evolutions and changes which has been happening. For example, you ask about crowns, there are stainless steel crowns, zirconia crown, now Figaro crown. All this evolution is slowly taking place, and the older materials or instruments are constantly being replaced by newer materials. So it is mandatory for us to know what exactly these newer materials are all about. Can it be used in clinical practice, whether it is giving us an excellent review or success for the patient? That is what we are more worried about. So if you go back and you see there are n number of crowns which has been in the practice for over a period of time. you have your polycarbonate crowns, strip crowns, the stainless steel crowns, you have your zirconia crowns, as well as the Figaro crowns. Now, I am not here to tell you the Figaro crown is the one of the best crown which is available for pediatric dentistry. I'm going to keep it very clean that there are a lot of crowns which are available. It is up to you to choose which one is the best for your own patient. Not all crowns or all the crowns which is available in market has its own advantage and disadvantage. Remember this particular point when it comes to your material choice or your instrument choice. There is no single material or instrument which is 100% successful. All the materials which is launched will have its own advantage and disadvantage. If you see this particular picture, my choice is always a strip crown or is always a stainless steel crown. Reason very simple, because I've been taught with strip crown, I've been taught with stainless steel crown. When I was doing my undergraduation, there was nothing else which is available. I will do a preparation, choose the strip crown, put a composite, load it, and then give a strip crown neat, cut it and take it out. Or I prepare the proximal surface and the occlusal surface, take one particular stainless steel crown, load it inside, keep it done. That is what my learning was. But now recently, even your parents have started asking you, sir, is there a different material which is available aesthetically? Because I want my kid to have a more aesthetical smile. That is one particular point which has been constantly happening over a period of time. That is the change which I also feel that there is some space for the new crowns which is coming into the market. That is the reason why the manufacturers also are trying a different crowns to be given for the your kids or the adult crown. So that is why it's been happening, and there is a lot of evolution which is happening and newer materials which has been coming up to the market. So what is all about my presentation? I always, when I present, I keep it simple, and I wanted to give a category to whoever is listening to this particular presentation. People who are listening to that particular presentation, I have divided you into 3 categories. Now, number 1, the category 1 people who are listening. Yes, I wanted to know what is Figaro crown. I wanted to get some knowledge about this Figaro crowns, and I wanted to know the properties, whether it is available or not. Because tomorrow somebody is asking me, I should tell, yes, I know Figaro crown. I can share some knowledge. That is category 1. Category 2 is, sir, I wanted to change it from stainless steel crown to the aesthetic crown. I really wanted to practice this Figaro crown in my clinical experience. I wanted to get it experienced and give it to my patient. That is category 2. Category 3 is my own postgraduate student. Sir, I am not worried about anything. Every day morning when I come to college, my guide is asking me to give some new topic for my research. Kindly help with some research aspect with Figaro crowns. This is category 3. So I've divided you all into category 3. You choose which category you fall. I will give you the information about the basic about the Figaro crown, the clinical aspect, how to be used for Figaro crown, and what research you can do about Figaro crowns. So the first aspect which you have to understand is why Figaro crown. Yes, it is all white. Now you get something, a crown which looks white. The moment, because you've been trained with stainless steel crown for a longer time, now you see a crown with the same shape and size in white in color. Wow. I just wanted to try this particular crown, and I wanted to know what exactly this crown is all about. So it's a white crown. It is metal free. Of course, if it is white, it's a metal free one, and this bisphenol free one, and it comes under a preformed size. So that is first you have to know about this particular Figaro crown. Now, what this Figaro stands for? If somebody is asking you what does this Figaro stands for, it is fiber glass reinforced crown. I repeat, it is a fiber glass reinforced crown. To be very open or honest, it is a composite crown. You will do a composite restoration, right? For your class 1 restoration or a class 2 restoration. It is same, but some glass particle is added to that, filler particle is added to that, and gives the strength of a crown so that it is available in a preformed size. That's all. That's all you have to know about the Figaro crown, which is the basic about the Figaro crown. Next, there's something they advertise saying that's a flexi technology. What do I mean by flexi technology is, when I take a crown and press it or compress it, it has that flexibility. Sir, even the stainless steel crown has something flexibility or malleability. Yes. When you compare with stainless steel crown, the flexibility is 2 times more. You can compress it to some more extent when you compare to the stainless steel crown. However, you cannot do that with your zirconia crowns. So that is called the flexible technology. Or when you place your Figaro crown into the tooth, it has that flexible nature and goes inside the undercut and gets locked. So that is what is called the flexible technology. And it has no subgingival preparation, because when you compare your stainless steel also, it doesn't need a subgingival preparation, or it needs only 0.5 of preparation. But this doesn't need a subgingival preparation, whereas your zirconia crown might need a subgingival preparation. So that's about your crown. So next aspect which you will have to know or understand is these Figaro crowns are radiolucent. Now, whenever I go for this presentation with Figaro, I ask them whether this is advantage or disadvantage. So everybody says it is disadvantage. For a simple reason is, you have a stainless steel crown picture on your right hand side, correct? You can see the extent of this particular stainless steel crown if it is a radio opaque crown. Obviously, correct. You wanted to place the crown and you see it, the margins are well adapted. Yes, that is an advantage of this particular stainless steel crown. So what these manufacturers are claiming is, see, I place a Figaro crown. If you see the radiograph which is there in your left hand side, it has a Figaro crown inside, but it is not visible, correct? So what happens is, there are situations where we give a crown for a vital tooth. For example, the large proximal caries, I prepare the proximal surface and give a crown. So in that particular situation, in case if there is a secondary caries, I repeat, in case if there is a secondary caries, I can visualize the secondary caries if the crown is a radiolucent crown. So it is an advantage. So this particular radiographic feature has its own advantage as well as disadvantage. Number one is, it is radio opaque. Subgingivally, you cannot, if there is a caries, you can just visualize the caries. But however, you cannot see the extent of this particular crown when you place it if it is radiolucent. So that is the one feature which you can see. Yes, these crowns are autoclavable. You can autoclave this particular crowns. That is one value added for this particular crowns. And the most important point is occlusal trimming. So which is not possible with your stainless steel crown or your zirconia crown. I told you already, this is a complete crown which is made up of composite. How you polish and trim the composite material, you can still do a composite, meaning trimming of this particular crown with your finishing burr. That is also possible with this particular crowns. And so preparation, how do I prepare this particular? I always give this rule 1.5. You prepare occlusally 1.5, proximally slice it to 1 mm or even 1.5 mm, and then you can give this particular crown. Burrs, the burrs which you are normally using for your stainless steel crown, your football shaped burr for your occlusal preparation, or occlusal reduction burr for your occlusal preparation, your thin needle burr for your proximal slicing, you can use the same burr for the finishing burr for your all the line angles to be rounded. You can definitely use the same burrs. There is no modification for this particular preparation. Luting cement, there are two luting cements which you can use. Either your resin modified luting cement you can use for your Figaro crowns, or your glass ionomer cement type 1 also can be used for your Figaro crowns. It is up to your choice. The retention of the crown with luting cement, the resin modified luting cement, and the GIC is more or less the same. So there is no difference in this particular thing. So you can either use your resin modified or the GIC cement for your luting. Selection of the crowns. Yes, it goes the same like your stainless steel crown. How do you select your stainless steel crown? Either you take an impression, measure the mesiodistal width, or you mesiodistal width and then you give the correct crown, or you go for a trial and error method. You take one size bigger, one size smaller, you try the crown, and which crown is fitting in, you can definitely use that particular crown for that particular tooth. So same thing, which is like stainless steel crown, you have the same selection method. All this is not a different thing which is available. It's all the same. So this is the particular picture which is available. If you see the box particular thing, it has a canine to be a valid advantage because canine strip crowns are not available. This particular box has a canine thing, incisor as well as molar. So this is about the figure of crown which is available in the thing. So you see the chart which is there on your screen. It looks confusing, right? When the moment this particular manufacturer sent me this particular picture, I was actually confused with what this is and what it says. It's a very difficult thing, and finally I understood this. So these are the tooth number. The 7585, 7484, 73 and 83. You have 72 as well as 71 and 81 and 82. You see this particular picture. 75 stands for your left second primary molar. So it's like small, extra small, small, medium, large, and extra large. I repeat, it is like extra small, small, medium, large, and extra large when you see this particular picture. So the extra small mesodistal width of this particular crown is 9.47. Your small size crown is 9.81. Your medium size is 10.16 and large size is 10.50 and extra large is 10.75. So there are 5 crowns which is available for one particular tooth. For 7.5 you have 5 different sizes. Whereas when you take your stainless steel crown, you have one more size which is added. So how to correlate with your stainless steel crown and your Figaro crown is, see, the extra small size is between 2 and 3 of your stainless steel crown. I repeat, the extra small size is between 2 and 3 size of your stainless steel crown. Your small size of Figaro crown is between 3 and 4 of your stainless steel crown. That goes same for your medium size, large size, and extra large size. That's how you choose your crown for this particular thing. So this is the mesodistal diameter for the upper. Same it goes for 6.5, 5.5, 6.4, 5.4, 6.3, 5.3, 6.2, 5.1. You have 5 sizes for 6.1 as well as 5.1. This is about your crown chart, what they have already given. So here we have a small video. See, people who fall under category 1, I've given you the information about what the Figaro crown is, how it is, what are the sizes which is available, how it goes. That's all you wanted to know. But here, excuse me for a minute. For this particular thing, what I'm going to play is for the practitioners. You can check how it is. I have added the voice also this particular so that you can easily understand. Once this particular video is done, I will explain what are the features which I wanted to tell you. Just have a careful look at this particular video, please.
Crowns are an important element in restorative dentistry for young children with high dental caries risk and who have already manifested caries lesions. Though stainless steel crown has been the most preferred choice in restoring primary molars, it is aesthetically not pleasing. Hence, we present to you a new aesthetic crown named Figaro, which is a biocompatible, metal-free, BPA-free fiberglass dental crown. On the screen, you can see a variety of materials and instruments which we may find useful in undertaking this procedure. This crown preparation is carried out in a series of simple steps. First, a large diamond or carbide burr is used to obtain occlusal reduction on both buccal and lingual cusp slopes. This reduction must be at least 1 mm. The occlusal clearance is then checked. Next, interproximal separation is obtained using diamond carbide burr. Care must be taken to avoid creation of a ledge interproximally. After the preparation is complete, we will seat the crown on the prepared tooth and then check the bite. The crown should be carefully removed using a hoe plier. The crown has to be trimmed at least by 1 millimeter. The bite is checked again using an articulating paper. The high points can be reduced using a finishing burr. Lutein glass ionomer cement should be loaded onto the crown and then the crown can be seated on the tooth. That brings us to the end of the preparation of Figaro crowns. Figaro crowns have a series of advantages which mainly include aesthetics and less tooth preparation. They are surely the future in restorative pediatric dentistry.
So that's about the Figaro crowns. The points which I wanted to tell you from the first armamentarium, yes. Now, if you hold on to this particular thing, you can have 1.5 to 2 mm of occlusal reduction. It is up to your thing, but the manufacturer recommendation is 1.5 mm. That is one particular thing. Next, if after you see the proximal reduction, see, these are the things which you are doing it for a stainless steel crown. One clinical aspect which you will have to remember is when you place this, you see a straight hole which is there in this particular picture. So when you do this particular trial and error, you cannot remove this with the spoon excavator because it's a composite material. There are chances of the margins getting deteriorated when you use a spoon excavator. So what the manufacturers recommend is when you place the straight hoe. I repeat, when you place the straight hoe on the buccal and the lingual surface and compress or give a pressure, this crown gets flexed and the crown automatically comes out. You understood the point? When you keep the straight hoe onto the buccal and the lingual surface and give a slight compressive force, the crown gets flexed and comes out. So that is one easy aspect when it comes to this particular Figaro crowns. That is about the clinical use of this particular crown. 1 second. So next, you see this particular picture on your thing. The modifications which is available for this particular Figaro crown is, in case if your central incisor, I repeat, in case your central incisor is very small, you can use your lateral incisor crown for the central incisor and modify or trim it like a central incisor. I repeat, you have a size which is very small for your central incisor. You cannot use this central incisor size crown. You can take your lateral incisor crown and place it towards the central incisor, and you can lute it and then modify this particular crown because it is a composite made material. Next, as we do for our stainless steel crown, where the upper crown is placed for the lower opposing side, that is also possible with your resin modified Figaro crowns. Even that you can do. So these are the clinical pictures which we have done with the Figaro crowns. To be very honest, this particular material is least researched. If you go into the literature and search about Figaro crowns, there is no much literature which is available about the Figaro crowns. You have hardly two to three articles which has been published with the Figaro crowns. Now there was first generation which was launched by Figaro crown. It had its own disadvantage. And now they have launched the second generation. I'll tell you what is the disadvantage of the first generation crowns. These are the first generation crowns which we used. If you see this particular clinical picture where we use for the anterior, after 2 weeks, this is the post-operative picture which is available. What happened with this particular case is there was a slight discoloration which happened with the Figaro crowns. This you will have to accept because it is a composite crown. It will obviously taken the color which is available, so it will definitely get stained. So that is one big disadvantage of using this particular Figaro crown when it comes to the clinical practice. Next, see the crowns which were being used for the upper and the lower. The preparation and the placement of the crown is very, very simple. There is no big procedure you will have to follow when you use this particular Figaro crown. It goes the same like your stainless steel crown. It's all the same. But the only thing is the aesthetic part over a period of follow-up. What we also felt was there is a constant discoloration which has been happening with the Figaro crowns. These are the clinical pictures which we done. So that's about the clinical point which you wanted to, you will have many doubts. I will definitely clear the doubts when it comes to clinical aspect. So that is about your clinical aspect of Figaro crowns. Now, when it comes to research, there are n number of research which you can do. I am going to talk about to the articles which is published with the Figaro crown. This particular article which was published in the Quintessence journal, the topic is the fiberglass crown with versus the preformed metal crowns in pulpotomized primary teeth, the randomized clinical trial. Now what they have done here in this particular aspect is Yes, it is a randomized, it is a consult guidelines checklist. What they have done is they have taken 16 patients with Figaro crown and 16 with your stainless steel crown. So, and they have followed up with 3 months and 6 months. Now, you will have to carefully understand what is the exact result of this particular thing. Now, you see this particular picture. So, they have evaluated the crown retention, the marginal integrity, the recurrent caries, the gingival index, plaque index, and color. So these thing will give you an idea about stainless steel crown and the Figaro crown. So what happens in the retention of the stainless steel crown and the Figaro crown? So the crown retention, intact crown, chipped crown, large loss, crown loss. When you see this particular picture, you see the 6 months follow-up with the Figaro crown retention leading to large loss. 8 of the crown is out, which means 50% of the crown is dislodged or large loss is there within 6 months. That is about the Figaro crown. But there is 0% when it comes to the stainless steel crown. When it comes to marginal integrity, there is no change which is happening. Recurrent caries, if you take, there is no recurrent, all this, there is no problem. When it comes with the gingival index thing, there is 4% of mild inflammation or 25% of inflammation within 6 months. That is with the Figaro crown. Plaque index, if you take, there is 13% of mild plaque when it comes to 6 months follow-up of this particular thing. And the final thing which you will have to understand is the color change. This is the most important point. When you take, there is obvious shade mismatch when it comes to 6 months follow-up of the Figaro crown. So that is what I told you. This particular crown has its own disadvantage and advantage. These are the disadvantages which is there with the Figaro crown. Now, what is the advantage? And you see this particular picture, 6 months follow-up, 50% of large loss. If you have done 13 patients, half of the patient, there is a loss in 50%, there is a loss of the Figaro crown, whereas your metal crown has no problem with even with the 6 months. So this is the disadvantage which I have been told about the Figaro crowns. Now, what is the advantage of this particular crown? This study we performed in our own department with our boss doing this particular study, our Dr. EMG Subramanian. So what we found out is this particular picture will give you an outline about stainless steel crown, your zirconia crown, as well as the Figaro crown. Now, you know there are 7 sizes in the stainless steel crown. You know the preparation of occlusal 1 to 1.5 mm, all that leveling, removal of any cervical stolers, all that is normal for the stainless steel crown. So zirconia crown, when it comes to, you will have much more reduction when it comes to zirconia crown, and these are the features which is available for the zirconia crown. When it comes to Figaro crown, I have already told you it has 5 sizes. You will have 1 to 1.5 to 2 mm of reduction. What is the advantage of key feature of this particular thing is pre-bevelaged margin. You will have a flexi fit. Polishing of that particular crown with high reduction, high point if is there, you can reduce this particular high points with the Figaro crown. That is the advantage. Next, which you will have to understand is this particular point. See, this is one point which I wanted to constantly say when it comes to your clinical practice. This is your choice. Now, I carefully understand this particular point. When you wanted to place a stainless steel crown, I repeat, when you wanted to place a stainless steel crown, you will have to reduce 7% of the tooth. For example, you have a patient whom you are going to place 7.5 crown. You will have to reduce the tooth material. 7% of the tooth material is reduced for that particular tooth to receive the stainless steel crown. However, when it comes to your zirconia crown, you will have to reduce 20% of the tooth for that particular tooth to take this particular zirconia crown, which means you will have to reduce 20% of the tooth structure to place the zirconia crown. But when it comes to Figaro crowns, you will have to reduce 12% of the tooth material to place the zirconia crown. It is like stainless steel crown is there, zirconia crown is there, in between is the Figaro crown. So what I would say is, if as a clinician, you wanted to worry about the tooth reduction, you can still choose the Figaro crown as a choice for placement, but not more than 6 months you can place this particular crown for your patient. For example, you have a patient who is under 7 years old, who is going to have an exfoliation over a period of 1 year, your choice, you can still go with the Figaro crown. Or you wanted to go for a zirconia crown, there is an option of a zirconia crown also. But when the color stability, retention, when it comes to Figaro crown is much less when compared to stainless steel crown, because as of now we have a research which is published saying that comparing the stainless steel crown and the Figaro crown. That's what I wanted to tell. The research area of this particular crown, Figaro crown, is much less, because it is one point is it is recently launched into market. Next, the study area is very less in this particular aspect. So what you can do is, for the postgraduate student, you can compare the stainless steel crown, you can compare the zirconia crown as well as the Figaro crown, and find which crown will have a longer duration in the oral cavity. Definitely, stainless steel crown will be your gold standard, which you will have to definitely accept that particular fact. But you can compare this zirconia crown, the Figaro crown, as well as the stainless steel crown, and do a randomized clinical trial over a period of 1 year, a minimum of 6 to 1 year, to identify which crown suits this particular thing for a longer duration. Because at the end, there are technologies which has been developing, but you will have to identify which particular crown suits your clinical practice. Either it is a stainless steel crown or a zirconia crown or a Figaro crown. Because there are these materials are recently launched and the research area is very less. You will have to identify all the lacunae and then use it in your patient for that particular successful. So these are about Figaro crowns, which is currently available, the details which is available, and the research aspect which is available with the Figaro crowns. So you can now tell me the questions and the doubts which is available for the Figaro crowns. I can definitely clear all the doubts. Now we can go for the questionnaire section if they have.
Thank you, Dr. Ganesh, for that very informative lecture, and it was very clearly explained in the most simplest way for us to understand. And we have 2 questions.
Yes.
Like it's regarding, they wanted to know the trimming of Figaro crowns. So how much we can trim and what burrs can be used to?
Yeah, correct. That's first question. You can trim your occlusal aspect for 1 mm. 1 mm of trimming in the occlusal aspect, as well as proximally you can trim, or the edges. What you can see how we trim the stainless steel crown. You can still trim them to 1 to 1.5 mm in the retention area also. Even that is possible. So the reduction will be 1 to 1.5 mm of trimming, and you can use your normal finishing burr, like the yellow banded finishing burr. You can use the same burr, or you can use the carbide burr to trim the crown. Both the things. I would advise the finishing burr, the yellow banded finishing burr in the occlusal aspect, and the carbide burr in the proximal surface, or in your margins.
Thank you, Dr. Ganesh. And we have another question. Can you please tell us what is the cost and who's the manufacturer of this Figaro crowns?
Availability.
And availability.
Yes. See, the manufacturer is from USA. It's a Figaro company who is manufacturing this particular company. This is from United States. And the cost of this particular crown is 1,300 rupees per crown. But now it has come down to 1,100 rupees. To be very open and honest, I am the person who brought this particular Figaro crown to India. The first generation crown was launched by our own M Dental person company, but that particular crown had a great disadvantage. I was not happy because irrespective of whatever material we launch, if the material is not proper, it's not working into the situation, we will have to accept the fact it is not working out. The first generation crown did not take up. It had its own disadvantage of discoloration. However, they improved the second generation, Figaro crowns, that particular crown, this color stability is somehow taken care. If you have to identify the first generation and second generation, in the proximal or the distal surface, you can see a blue color coded printing. That is the second generation Figaro crown, you will have to take it. The first generation had a silver color printing. However, the second generation has the blue color coded printing of the size. So that is the second generation. Now, second generation is actually going on well. Since the first generation had a lot of problem, people were reluctant to use this Figaro crowns. Now, slowly they started using Figaro crown. Over a period of time, they might find a way as a clinical success. That is what I personally feel with the Figaro crown.
Thank you, Ganesh. Ganesh, I still have one doubt which popped up in my mind.
Yes, sir.
Because there was a question between first generation and second generation, and you clearly mentioned that it's between the silver and the blue line.
Printing, yes.
But what was has any physical property been changed, or what is the?
Yes, the physical, the filler particle content and the glass particle added in that particular cone is added more. So that the color, which is, see, the composite restoration, sir, has the ability to accept the color. It will just take up the color whatever we are eating. So they added some filler particle, and the micro hardness of that particular material was improved, and as well as the glass fiber which was there, they made it as a mesh network and added to that particular thing. So the color stability was more in second generation when compared to the first generation.
Now, it's pretty new for me also. So we wanted to try this in our department. So I have one quick question again.
Yes.
So the preparation, what I understood, is almost similar to stainless steel crown. We can't trim the buccal and lingual side. We can trim only on the occlusal surface for 1 mm with polishing burr and the proximal with tungsten carbide. Am I right? Is it
simple? It's simple.
Okay.
Yes, you're correct. You're correct.
And the buccal and lingual, we can't trim only because it can fracture there, because it's composite based kind of material. Is it like that?
Yeah, it is not like we cannot trim the buccal and lingual aspects here. You can still use the finishing burr and trim. But most of the situation, you might not require to trim the buccal and the lingual aspect of the crown. It is not necessary because it is the same size of the stainless steel crown which is available. We don't touch the buccal and the lingual surface. It is not required. The only problem will be, sir, if I place a stainless steel crown, even if there is 0.5 mm of high points, there are chances of the stainless steel to get adapted over a period of time. But this will not get adapted, nor your zirconia crown will not get adapted. So for that, you can place your articulating paper and trim like your composite restoration, how we do. That is 1 mm is acceptable, this particular thing. Still, it doesn't fracture. The hardness of this particular material is well and good. It doesn't fracture. But we recommend only 1 mm of occlusal reduction. And you in the margins also, if it is over, the height of the crown is more, you can reduce to 1 to 1.5 mm using your carbide burr. That is also possible. Like how we trim our stainless steel crown in the margins to get it adapted to the occlusal height is reduced, we can still do it with the zirconia crown. All this is not possible with your zirconia crown. Only your stainless steel crown or your Figaro crown, you can touch your marginal surface so that you can reduce the height of that particular crown. That is not possible with the zirconia crown. That is what. So every material has its own disadvantage and advantage. When it compare, when I started also, I felt Figaro crown was much comfortable. But when you follow the crowns, it seems like have a disadvantage when compared to stainless steel and the zirconia crown.
Yeah, I think that was the next question, Professor Nupur from Meerut. She has a question for you.
Yes,
what would be your choice of crowns for pedo patients, especially for anteriors and posteriors? I told you, I think when I requested you for this lecture, I wanted you to give us your experience into Figaro crowns. Where exactly do you think we can advise this? Where do you think we should still opt to go for stainless steel crown? And where can we go for zirconia? Zirconia, again, it's expensive. People, if they can afford, it's fine. But what is your experience in choosing so that practitioners would be benefited with that?
Yes.
Your take on that.
My experience with the zirconia, the Figaro crown is, to be very open, I am a stainless steel crown person. To be very honest, for molar, nothing like stainless steel crown. You can replace the stainless steel crown. If you have a stainless steel crown which is white in color, that is the best thing which you can have. When it comes to,
I think I will go with that too.
Yes,
I will go with that too. Maybe old time thing. I think Dr. Nupur. please.
Yes, yes. Even if it is old, it is the gold standard because your technique, your thing, your patient adaptation, your crown adaptation, everything is excellent with stainless steel crown. When it comes to Figaro crown, I have a patient who's demanding me a aesthetic crown. Okay, and I have only 1 year to 1.5 years of follow-up. Within that 1 year or 1.5 years, the tooth will exfoliate. I go for a Figaro crown. Okay, and I wanted to preserve my tooth structure. Then my choice will definitely be a Figaro crown because zirconia crown needs a lot of preparation. For example, we have anterior tooth structure which is very thin. No, ma'am. After we do pulpectomy, you see there is only one spike of tooth material which is available. In that particular case, I can prepare and push this Figaro crown subgingivally. So it has a flexible fit and gets long and retention is better. But that you cannot do to the zirconia crown because you have a passive fit. There are chances of less tooth material and the zirconia crown falling out. People who are into zirconia crown will never accept this. I will have to, because that is one thing because they feel that the retention of the crown is again with the cement what we place. But crown also plays a very important role. Your preparation, your crown, as well as the luting cement. If you take McDonald says this particular point, it is the cement which is helping for the retention. My own take is your tooth structure, your material of choice, your luting. All three has an equal advantage of your retention of your crown, whatever it is. So at the end, I have 6 months to 1 year follow-up. I go for Figaro crown. If the patient is asking for aesthetic crowns. Definitely, that is my choice. Or still, no way. I am happy with zirconia, stainless steel crown. I go with the stainless steel crown. Now the stainless steel crown is available in the gold color also. That is one fantasy which is happening. This one we tried one with our department also. I have a gold tooth inside. That's what kids say. They might take that as one of the most advantage thing. We don't know what exactly is the future of this particular crowns, but yes. This Figaro crown will still be in market for some time. There are people who are using Figaro crown. I have one particular person. They started with Figaro crown. They are still in Figaro crown. There are bias. It's not like there is no bias at all. They are with Figaro crowns only. So I feel this is your own choice of this particular crown.
Thank you, Ganesh, for that honest answer, because actually everybody wants to try, because if it's composite, some people are composite people. They like their composite crowns, and people want a choice of a lesser economical or a more economical crown, not an expensive like zirconia crowns. And people don't want to do preparations. Some people don't want to trim the tooth. They don't want to do, they can modify only the crowns. See, I'm still in that old school of that. I wouldn't chop down the tooth structure, right? I'm sure the next speakers are going to come and say a different opinion because they will be talking on zirconia crowns. Yes. But that's exactly why we had an array of speakers to ask their experience on why and where to use which kind of crowns. And there's one last question from Dr. Pratyusha. Can we use Hall technique for Figaro? I think it might not really be possible for without preparation, right?
It is not possible. It is not possible without preparation. You will definitely have a high point with this particular crowns which you place. Because the crown has its own height and the occlusal morphology, it will definitely hit. See, Hall's technique of stainless steel crown is 100% successful because the crown gets adapted over a period of time. It has that malleability and ductility. It will just get adapted. None of the other crown will take that particular property. You will have to invent a new material which is equal to the property of stainless steel crown and do that. Composite restoration, your zirconia, nothing else can replace your stainless steel crown or figure out whatever it is. That's my honest take of, as Sir said, when Sir asked me also, he told me, you give your own opinion about Figaro crown. I think I am very honest in giving the opinion about the Figaro crown. I accept the fact that we were the person who launched this Figaro crown, but if it is a disadvantage, it is a disadvantage. If it is an advantage, it has its own advantage.
Thank you, Ganesh, for that wonderful yeah, I think we have a couple more questions, but before I ask that questions, thank you for accepting this lecture, because I wanted you to talk about this topic because you are the one who actually brought it into our currency. So I thought you should be the best person to tell both the advantages and disadvantages. I agree with you totally that if you ask me whether after listening to your lecture, will I use Figaro? Yes, I will. because I know that I don't want to use zirconia, right? So if I don't want to use zirconia, then if it's not needed in some cases, and patients in my hometown can't really afford that kind of thing, then still they want an aesthetic crown. And if it's unguarded prognosis, I might still say, okay, I might take up this chance, right? And I'm really happy to have you always with my team, and I've seen you right from the undergraduation, post graduation, and now being an entrepreneur. Thank you so much, Ganesh, to accept our invitation as well. I think we have okay, back-to-back Figaro crowns. Is it possible, and how to modify? High point, will it get adjusted like stainless steel crown? I think you have answered that question, that it won't get adjusted like the high points like stainless steel crown. But back-to-back Figaro crowns, any experience on that, Ganesh?
Yeah, you can definitely go do a back-to-back Figaro crown. Same technique like your stainless steel crown. You place the distal most tooth and then the mesial tooth. Same, because it has that flexible thing. When you place it inside, it gets that flexibility, and both the proximal surface will have a flexible nature and goes in. So back-to-back stainless steel, meaning Figaro crown, is also possible. Definitely you can try. There's no disadvantage over that.
Thank you, Ganesh. Thank you for sparing your time and sharing your experience and knowledge on Figaro crowns with all of us today.
Thank you.
As a token of gratitude, we would like to present you with a small certificate of appreciation.
Yes. Thank you so much, sir. Thank you so much for the certificate. Whenever I receive a call from you, I always have in my mind saying that I should not say no. Okay, that's what when you call me and said, because you've been teaching me from undergraduate thing. I am now teaching whatever you have taught to me to my particular students. You can ask your own department people. Dr. Darshini is there. She is my student only. Whatever you taught in pediatric dentistry, that is what I am also teaching in pediatric dentistry, and whatever we have learned also doing. So I repeat again, whenever you call and ask for something, the answer is will be definitely yes, there will be no. Okay, that is what.
Thank you so much, Ganesh, because it's all about you students who actually keep us thinking, right? See, I still remember the day when you came up with that file system in Meenakshi Ammal Dental College. And I know it's gone a long way, and hearty congratulations to everything you do, and all the very best. Thank you so much.
Thank you so much for the opportunity. Thank you, ma'am. Thank you so much.
Thank you.
May I now request Dr. Darshini to introduce our second speaker for the day, Dr. Milan.
A very good morning to all. I'm happy to welcome our next speaker of the day, Dr. Milan Shah. He graduated from Mahatma Gandhi Mission Dental College and Hospital, Navi Mumbai, and pursued his master's in Pediatric and Preventive Dentistry from DS Dental College, Bangalore. He has an exclusive pediatric dental practice, The Little Smiles, in Mumbai. He's received the award of Best Scientific Paper in the 35th ISPPD National Conference held in Jaipur. He was nominated the category of Best Periodontist of the Year at the FAMDent Excellence of Dentistry Awards in 2015 and 16. He is invited as guest speaker at various platforms across the country, and he has also authored a chapter in the textbook of Pediatric Dentistry by Dr. Nikhil Marwa. He regularly conducts comprehensive clinical periodontics courses all over the India. Today, he will enlighten us on zirconia crowns in pediatric dentistry. We're happy to have you here, sir. We welcome you.
A very good morning to one and all. Am I audible?
Yes, doctor. I think you can share your screen. We have made you to.
Yeah. Just 1 second.
Morning, Milan.
Good morning, sir. Good morning, sir. Thanks a lot.
Yeah, and I'm hoping you will say zirconia crowns are going to do wonders, right?
Definitely,
yeah.
Definitely. Hopefully, after the presentation, I'm able to share my experience and convey the message.
Yes.
So thanks a lot, sir. I'll share the screen right away. Yeah, just. Is my presentation visible now?
Yes.
And my voice is also clear, right?
It's clear.
Yes. A very good morning to one and all. So let us begin with zirconia crowns in pediatric dentistry. So just before starting, as we all know, that today we are here basically for a change. I'm sure most of us have had experience with pediatric zirconia crowns, and some of you might be willing to start this new modality of pediatric aesthetic treatment. As we all know that the only thing which is constant in life is change. Change has always given something best to mankind, as we all know. And dentistry has also seen a lot of change over the last few decades. If we consider other fields of dentistry, we have seen that in terms of X-rays, in terms of other treatment modalities, we've seen a lot of changes. As you can see, implants, and now where all they put implants, there are zygomatic implants. They put implants in the pterygoids. So all these are the latest advances which have been developed in dentistry. And in terms of full coverage restorations, we know that PFM to metal free has been a game changer, and it has changed almost everything in restorative dentistry because the more aesthetics and the more better restorations. So better material generally give us better results, and it is not only about the quality of materials, but it also gives us the brings us the best quality to life. So let us all come out of our comfort zone and enter into a new dimension, a new area where we can see some magic happening. So let us begin with the presentation, which is preformed zirconia crowns in pediatric dentistry. I will be covering the presentation under the following contents. So, and towards the end, I'm going to share a lot of clinical cases with a lot of follow-ups as well. So just before beginning the presentation, I just want to brief about what are the other options, what are the overall options in pediatric dentistry regarding full coverage restoration. So as we all know, we've got stainless steel crowns for anteriors as well as posteriors. For anteriors nowadays, it is not very much in use. Then for anteriors, basically, we've got strip crowns as well, which are very much in use and which are very commonly used. Even today in my practice, I use a lot of strip crowns. So today, if we consider the two main options for anterior restoration in Pedo, then probably we can consider strip crowns and zirconia crowns as the two majorly used restorations for anterior tooth. Stainless steel crown, as we all know, have been used widely in the past, and still they are considered as the best possible full coverage restoration for posterior tooth. I cannot say that for anterior tooth, but for posterior, still they are the best restorations. So, considering the options for to restore carious anterior tooth, we have got strip crowns and zirconia crowns, as I just spoke about. So in short, I just want to discuss the few difference between strip crowns and zirconia crowns. As we all know, strip crowns
Dr. Milan? I think he's got a network issue. Dr. Milan? Milan, can you unmute?
Yes, yes. Am I audible now?
Yeah, you are audible. You can share your slides now.
Yeah. Is it visible now?
Yes, it's clear now. You can continue.
So we were talking about the difference between strip crowns and zirconia crowns. So basically, as I said, strip crowns are more time consuming. They've got higher chances of breakage and fracture. They're slightly more technique sensitive because it involves the bonding procedure. Over a period of time in the follow-up cases, I have noticed that it accumulates a lot of plaque over a period of time in case the child does not maintain properly. Also, they could be less aesthetic because of that same reason. So over a period of time in the follow-up, we can probably find the strip crowns, they don't look as aesthetic as they used to look when we have placed it during the immediate post-operative phase. So this is the post-operative image, as you can see in the images below, that probably after 2 years or 3 years, this is what it looks like. There are chances that it might get chipped or fracture at some point, and the color of the strip crowns also becomes dull after a period of time. And when talking about zirconia, they are less time consuming. They've got less chances of breakage, comparatively less technique sensitive because it's type 1 GIC. They've got a highly polished
Dr. Milan? Dr. Milan, can you hear us?
yeah.
You can share your slide.
Right. So let's talk about the step-by-step procedure of zirconia crown preparation. Talking about the anterior tooth preparation, the first step is to select the crown. So how do we select the crown? Basically, we check the mesiodistal width of the crown and compare it with the mesiodistal width of the tooth, and that is how we select the crown. Followed by, we do the incisal preparation, which is approximately 1.5 to 2 millimeters to get the adequate incisal clearance. Then we have to do a supragingival preparation, and in which we have to prepare the buccal, the palatal, as well as the proximal part of the tooth. So we have to overall prepare approximately 1.5 millimeter. That will be the supragingival preparation. And then the most important part of the tooth preparation would be the subgingival preparation. We have to do approximately 1.5 to 2 millimeters at least subgingival preparation, 360 degrees, like buccal, proximal, as well as the palatal area. So that is the most important step of tooth preparation. The zirconia crown basically take their maximum retention from the subgingival healthy tooth structure. Then we have to check the fit of the zirconia crown. So basically, unlike stainless steel crowns, zirconia crowns have to fit passively. We cannot have an active fit with zirconia crown, because zirconia, being a brittle material, have got chances of fracture. So we have to have a passive fit with the zirconia crown. So once we have checked the fit of the crown, then comes glass ionomer cement. So a normal type 1 glass ionomer cement is what is required to cement, and there is no such need for any resin based cement to loot a zirconia crown. Even normal type 1 glass ionomer cement is going to give us the best results. So basically, in short, if we say after we give adequate local anesthesia, buccal as well as palatal, coming to incisal preparation, then supragingival preparation, proximal preparation, and towards the end, the most important is subgingival preparation. So I just would like to share a short video on a model regarding how we prepare a tooth for to place a zirconia crown. So as I said, subgingival preparation is the key. So we have to use a very thin tapered fissure burr in order to create a subgingival preparation. There should be no chamfer or shoulder. So that basically there are no margins which is required. We do not want any ledge or any kind of a margin in the subgingival area of the tooth. Now just let's discuss some of the clinical cases and few videos on patients as well. We are going to discuss. So let's consider this particular tooth wherein, as you can see, the tooth number 61 is grossly decayed. So this is how the tooth preparation looks like. And this is the immediate post-operative image. As you can notice, some amount of bleeding around the gingiva, which is a very common phenomenon after placing a zirconia crown, because zirconia crowns are to be placed subgingivally. So this kind of a bleeding is noticed during the immediate post-operative phase. But just within 1 week or 10 days maximum, you can see how beautifully the gums get healed and they get adapted properly to the zirconia crown. And you can see how well the color has been matched. So just to show you how much tooth preparation we generally do for a zirconia crown. So as you can compare it with the adjacent tooth, this is the amount of tooth that we have to prepare for a zirconia crown. In our practice, most of the times we select cases for zirconia crown for smile designing, those incisors which are generally grossly decayed, which have got less of enamel left on the tooth. So those kind of cases are generally ideal cases for zirconia crowns. And those cases which have got just very less caries, or which have got adequate enamel left, I still feel that strip crowns would be the more conservative option in those kind of cases. But the cases which we are going to discuss in this presentation are most of the cases, all the grossly decayed tooth, which are ideal for these kind of zirconia crowns. Also, we can do zirconia crowns for posterior teeth as well, because nowadays a lot of patients are concerned with aesthetics. So even for a posterior tooth, they demand aesthetic crowns in some of the cases. So just wanted to show you the amount of tooth preparation that we have to do in when we are preparing a molar tooth. So this is the image clearly which shows how much tooth we have prepared. The same steps as the anterior tooth, but most important part again is a subgingival tooth reduction. So as you can see this clearly how much tooth we have reduced for placing a zirconia crown, and they have to fit passively on the tooth. So just see the healing just after 1 week. As you can see how beautifully the gums have healed and there is no bleeding. So we just have to inform the parents as well that for a period of 1 week or 10 days, probably while brushing the tooth around the zirconia crown, there could be slight bleeding. So just let us inform the parents beforehand that this normal thing can happen for around 1 week, but gradually it is going to settle down once the gums heal. Just a small video for posterior tooth preparation before we show some videos on patients as well. So first will be supragingival preparation, and towards the end we do the subgingival preparation. And also regarding occlusion for a molar tooth, when we are preparing for zirconia, so same like stainless steel crown, like the occlusion gets adjusted within a week or 10 days maximum, even if it is left high by 0.5 to 1 millimeters. So the same concept is being followed as in stainless steel crown in terms of occlusion. So these are some of the cases for posterior tooth. As you can see over here, this case, this is the immediate post-operative image wherein we can see a lot of bleeding which is there
when I was a young warthog. How you feeling? It's an emotional story. He found his aroma lacked a certain appeal. He could clear the savannah after every meal. I'm a sensitive soul.
So let's discuss the open secrets that you need to take care of when you are preparing the surfaces for your zirconium crown. It's a myth or it's a misnomer that it needs a lot of tooth structure loss that happens when you're placing your zirconium crowns. It's a learning curve, I agree, but eventually your preparations are going to get conservative to the extent that you will be able to do vital zirconium crowns as we did for 5.2 and 6.2 in over here. 5.1, 6.1 had to be treated for pulp therapy, and that's which were followed by your zirconium crowns. The other trick over here is to control the bleed. The third one being that your incisal edges, if you want the incisal edge of your final restoration to be matching each other, make sure that your prepared surfaces incisal edges are also matching. We have this habit of taking pictures during the procedures, and we get back to our pictures to see whether the incisal edges are right or not. The best part about New Smile was to have something called as trial crowns. You could see that I had to check the fit of the crown at least 2 to 3 times before I could finally note my restoration. Now, what impact does a contaminated intaglio surface of a zirconium crown have? And what is the right way to treat that surface? Is it your phosphoric acid or your alcohol wipe that we are using in our clinical practice? You will see the amount of tensile bond strength reduction. For the non-contaminated surface, it's about 35 MPa, and that's what we want to reach to, and that's what we want to give to in our final restoration. Now, with your pink trial crowns, you are able to do that. Whereas in case you're using any other brand of your zirconium crown and your intaglio surface is going to get contaminated with your blood or your saliva, you have to understand that the zirconium has great affinity for the phosphate groups, which is present in your saliva. So maximum amount of intaglio surface is already interacted with your saliva, and there's very little amount of surface remaining for your luting cement to interact with your intaglio surface. It will interact with the prepared surface of the tooth because that's not contaminated, but you have to make sure that you clean your intaglio surface with something called as IvoClean. Now, your IvoClean is basically an alkaline suspension of your microfilled aluminum oxide particles. So they are present in good amount of concentration, and the particle size is so small that your zirconium oxide present in your IvoClean will interact instead of your intaglio surface interacting with the phosphate group of the saliva. So with your IvoClean, you are able to match the tensile bond strength of an uncontaminated or a non-contaminated crown. And that's another clinical secret that we would like to share, and make sure that you invest into this material. Now, these were surfaces which we treated because there was some amount of tooth structure to hold on to. But what about those children who come at the end stage and there's hardly any tooth structure remaining? The radiograph does not allow any restoration to be done, any root canal to be done, and the only treatment option remaining is your extraction. So this was a relative's child who sent me pictures that they have done a 4-unit bridge down south in Bangalore. And I was wondering how long this is going to stay. They came back and they told me that the appliance fractured 2 to 3 times. They had to re-cement it, and the child had to go for a function. So that's the kind of destruction that has already happened. What I had to do was just to give him a temporary, just to give the child a temporary restoration. I noted this with type 1 GIC, and I told her that we need to go in for a definitive restoration now. So that's the extracted tooth. See the amount of post-space preparation that was done, jeopardizing any peripheral healthy tooth structure that was remaining. And that what eventually led to the fracture of the restoration. So that's another factor that we need to look into as to how much post space that we're creating when we want to take support from the intraradicular portion of the root. That's the 4-unit bridge that was delivered, and it's finally out of the child's mouth. And we restored 5-1 and 5-2 with zirconium. And we gave a Gropper's appliance for 6-1 and 6-2. The Gropper's appliance was modified in such a manner to minimize the amount of acrylic that would go into the child's mouth. And this is how we did the metal framework. We prepared the composite shells that would go onto the metal framework. And that's how it appears once it's finally onto the framework. You see hardly any acrylic that is seen. And this was after cementation of the appliance into the mouth. 6-1, 6-2 was restored, and the child was happy. This was a 6-month follow-up. That's a 12-month follow-up. That's an 18-month follow-up for the particular restoration. So Sharat sir told me that to cover about aesthetic restorations in young permanent anteriors. So let's look at the role of BioClear in dental traumatology. Now, the BioClear concept of injection molding is basically they utilize something called as single shade philosophy. They believe in using the body shades of the composite. They believe in extending or giving an infinite bevel. The only disadvantage being that you're not able to give the kind of characterization as you see in 1-1 that you won't be able to give in 1-2 if you've opted for an injection molded restoration the BioClear way. These are the BioFit Clear matrices with a diamond wedge in place, and we injection molded this restoration. Aesthetically, it is pleasing, but if you go in closer, you won't be able to give those finer details that you see in 1-1. And that's an 18-month follow-up of the injection molded restoration. The restorations are right here. It's flushed well with the tooth structure, but the oral hygiene seems to be poor for this child. Another case of complicated crown fracture where the fragment reattachment was done using heated composite, and we used the body shade to mask the point of contact between the fragment and the prepared existing tooth surface in the mouth. So we did a Schweck pulpotomy, disinfected it with 2% sodium hypochlorite, followed by your biodentine placement, followed by your resin modified glass ionomer cement, because you want a material of the same family that will interact with your composite. So we gave an infinite bevel on to the broken fragment. We gave an infinite bevel on the existing tooth structure in the mouth. And that's the amount of gap that was filled with the heated composite. The initial loot that we did for this case was we used a material called as Flows-Right by Pulpdent, which is a universal shade, and it masks and it flushes with the color of the tooth. And that's how the case was taken to completion. And that's a 12-month follow-up, and everything is intact and in total. However, when you have young patients who are demanding and you want to go that extra mile of putting those stains, you cannot go the injection molding way. You have to go, we follow the Styletania shade recipe. Let's look at this case. So this was an uncomplicated crown fracture. We prepared the tooth surface. The wax up was already done. The putty index was made to prepare the palatal shell using the enamel shade. Since we wanted to get the final shade as A2, my dentinal layer was A2 and the enamel was A3. So what you see as the enamel shell is basically the A3 shade. Then we packed the dentinal shade A2. Make sure that your dentine, you use a brush to brush the dentine over the prepared surface at the bevel so that your final restoration does not show that margin. We added a few white stains in this to simulate nature, and that's the final restoration that we could give to that young child, and that's a 24-month follow-up. But you must be exasperated with the amount of steps that were involved, and now we have better materials which will take away those steps, and we have something called as Omnichroma now, which is available by Tokuyama. There are two shades only. One is the blocker, which will replace your dentine, and the other is your Omnichroma, which will replace your enamel. Now, this is based on something called as a smart chromatic technology, wherein the entire particle size of the composite, when you see under the SEM, you see a uniform spherical particle size of 260 nanometers. Whereas the other composites, you will see some particles will be 300 nanometers, some will be 200 nanometers. And because of the discrepancy in these composites, that is what contributes to the improper shade matching. So these guys came specifically with this 260 nanometer spherical particles, and they are uniform throughout the composite. So the red and the yellow color that is reflected is basically, it is going to reflect the peripheral shade of the prepared tooth. So if the tooth is A2 and you have packed your Omnichroma, what will meet your eye is just going to be A2 because of the uniform particle size, and this is basically the smart chromatic technology. So let's look at a case. This child reported to us with a complicated fracture. He reported almost 72 hours later, so Schweck was out. We did a single visit root canal. We backfill. We downpacked first the apical 5 mm, then we backfill with warm gutta percha. We filled the entrance with your resin modified glass ionomer, and then we started preparing the surface. An important point that I have missed all this while is to make sure that the surface which is going to receive any composite restoration is plaque free. So what we use is something called as a blaster, which is going to remove the acquired pellicle or the acquired biofilm from the tooth surface. Because if you don't remove that, that is going to affect the outcome of your restoration eventually. So what you see over here is that we have prepared the palatal shell using your Omnichrome, because that is what is going to replace your enamel. Then we replace the enamel at the mesial and the distal line angles. And then we packed the blocker, which is going to replace your dentine. Make sure your dentine is going to be thick near the cervical third. And as it tapers incisally, you have to make sure that the thickness of your blocker layer is also gradually coming down, as you see in the picture over here. We have added the blocker stain over here at the incisal margins as well in the mamelon area. And the final layer was done again with your Omnichrome. This is the finished product that you see in the slide to your left. And this is the final polished restoration. You see how the shades is blending with the shade of the natural tooth structure. So be it A1, be it A2, or be it A3, it's just these two materials that you need now. And I'm very happy with the outcome that we've got in this particular case. You see that the material is flushing well with the enamel margins, 360 degree. And there is a good amount of peripheral seal, which will eventually contribute to the success of your restoration. Let's look at another case of Omnichroma in a class 3 restoration. So we started preparing the surface. We gave an infinite bevel again. Here, since we are just into enamel, we are just going to use the Omnichroma. And that's the final outcome after your finishing and polishing. You see how the restoration has blended with the tooth structure, and it is blended with the remaining amount of whatever the enamel was present to grab onto. Another case of complicated crown fracture. The dilemma over here was the root apex of this child was open. So in case I had to restore this case, I had to do some fiber post followed by a crown. So what we did was we did something called as a deep-seated pulpotomy. We went in almost more than 5 millimeters and removed the coronal portion of the pulp. We packed in biodentine and restored the remaining portion with your resin modified glass ionomer cement. We attended to the tooth again after a month, and what we did was we removed the RMGI that was placed in from the intraradicular portion. We used a glass fiber post which went in almost 5 millimeters and extended out almost 3 millimeters. And then we did the final build up with the composite restoration. And you can see over here that the apices that were open has eventually gone to completion. You can see a dentinal bridge that has been laid down over here because of the bioceramic. And you can see a good peripheral seal 360 degree over here. And that's almost a 2-year follow-up that we have with this child. So finally coming to the open secrets in dental traumatology, the first being isolation. The second being make sure that you've disrupted the biofilm. The third being that you take care, you prepare the surface for the infinite bevel so that your final restoration masks the fractured margin as you see in this particular case. So as pediatric dentists, we need to simplify our task and we need to continually look for faster, better, and easier ways to get our job done. And we've invested in these materials. That's a composite Walmer by Aesthetics, the blaster, which is going to remove the biofilm. And I guess we all should invest into these materials. Other essential tools is your loops, your electrocautery, and a non-squirming child. And to have a non-squirming child on the chair and to create this kind of magic on the chair, you need laughing gas, you need different forms of sedation, because these procedures are obviously going to extend for more than half an hour or 45 minutes. And no amount of vocal anesthesia is going to substantiate or replace your laughing gas in your practice. So let's see how we have used our materials to our advantage. So this was a child who was treated under general anesthesia. Within a month, the restoration with 5-2 was dislodged. Now, looking at the pictures, I'm sure you must have guessed the reasons. The white apex has not been cleaned from the walls. The glass ionomer was just packed as a putty. The gums have not been taken care of. In fact, it led to more inflammation and bogginess of the gums, which I had to trim with my electrocautery. So we cleaned the inner surface. We packed the inner surface with your inoseal. We then used a flowable composite and we finally used the A1 body shape. So that's the difference that you can make into the child's smile, and you can give predictable restorations in your practice as well. So see the amount of open margins that putty glass ionomer was causing, the overhang, and see how we have given a flushed restoration and with good aesthetics. So it's not just about the materials that count, it's eventually your mindset as well. We need to change our mindset that these are temporary teeth, so it's okay to give them temporary solutions. But please understand that these are going to be there in the mouth, serving the child for good 5 to 6 years or 7 years. So let your work speak, let your passion speak for you, trust yourself, keep doing ethical work, and success will follow. So thank you everyone for taking the plunge with us. If anyone wishes to dive deeper, we have these LMS website of us under the banner of Pedo Zen, passionate pediatric dentistry at its zenith. You guys can have a look. So the takeaway message is children are great little people. They're always full of stories and surprises and keep us on our toes. There is a great satisfaction for us when we, with our innovative and ever-evolving approach, makes an apprehensive child realize, yes, I can do this. So let's create these memories more and more. I bow down to the godliness that dwells in all of you. Thank you for your patient listening. And you can reach out to us over here. Thank you, sir.
Thank you, Abhishek. That was an excellent presentation. I couldn't have asked for anything more. I think you proved me right again. I'm choosing you as not the tail-ender batsman, but a perfect finisher. Right? I was definitely very confident that you would be the apt person to finish that. Thank you so much for agreeing. As soon as I called, I think you, without even hesitation, you agreed. And this is exactly what I wanted, and I couldn't have asked for anything more from you. Thank you so much, Abhishek.
Thank you.
Over to you. Have a few questions to answer.
Sure.
We have a couple of more minutes with us. Yeah. Thank you.
Sure.
Thank you, Dr. Abhishek, for that excellent coverage of the art of restoring back the pedo aesthetics and excellent photography and videos and documentation, which we have to learn from you all. And we have few questions for you. So the first question is, can zirconia crowns be manipulated, like any crimping procedures or something which can be done?
So zirconium is a hard white metal. It's not a malleable metal. So you cannot do anything at the cervical margin. You can only trim the cervical margins. But there are special kits which are available so that you can restore the final polish of your zirconium. Otherwise, you will initiate cracks if you have not taken your prepared zirconium surface to that final polish and glaze. So there will be times when in a crowded dentition or a closed dentition, when you're trying to put your two crowns together, the mesial surface of your zirconium is not allowing the same. So that is the time when you may have to trim the mesial surface of both your 5-1 and 6-1 so that they can go in a straight line path of insertion. Because if you see or follow up a few cases, you will see that sometimes one of the crown is probably labially placed, or sometimes they are rotated. That is basically a compensatory phenomena, because if you have the right materials to prepare the surfaces, you have to make sure that you prepare the surfaces on the mesial side of your crowns as they enter into the child's mouth.
A question by Dr. Raghavendra. What is the role of hydrogen peroxide in one of the cases I think you have treated?
I'm using hydrogen peroxide as a hemostat. So it immediately arrests the clavicular bleed. So even if your viscostat clear does not work, your hydrogen peroxide will definitely work to arrest the bleeding.
Thank you. And the next question is by Dr. Nandita. Could you please elaborate a bit more on using Activa by Pulp Dent? So do we need to clean the tooth surface with any particular material prior to the?
So what we do with our preparations, ma'am, the surfaces are always blasted once the preparation is done to take care of the biofilm. For Bioactiva, there are two schools of thought, but I prefer to do selective etch followed by a universal bond application and followed by your Bioactiva. There are studies which suggest that even for a bonded surface, there is still going to be ionic exchange between the interior surface of the tooth, while the exterior ionic exchange is always going to be happen because of the good amount of fluoride release that keeps happening.
Thank you, Abhishek. There's one question from Dr. Sunil from UAE. What exactly is intensive fluoride application, and how different is it from conventional fluoride application?
So intensive fluoride is what I got to learn from Dr. Muthu, and you will find a lot of studies also on the same, sir. So what we've started doing is, some parents who do not agree with the black discoloration, we give them the option of the intensive fluoride regimen with diligent home hygiene protocols that are already shared with the parents. So intensive fluoride is basically wherein we are doing spot applications. We are doing 4 applications, that is 1 application every week in the first month, followed by 1 application every month for the next 2 months. So 3 months are over. This 3 months is good enough to understand whether the parents are in tandem with your home hygiene protocol or not. If the parents are not in tandem with you and you are not seeing any resolution with the white patches, that's when we suggest to the parents that it's better to go for the SDF. We have aesthetic options to cover them up later on. But if you see resolution of the white patches happening, since we are documenting, we always compare the pictures of our pre-ops with the ones after 1 month, 3 months, and parents are also able to appreciate the change. And we appreciate their efforts if you see significant amount of changes happening and they're motivated enough to take up those cases. So some cases we've managed only with fluoride because the parents did not want any black discoloration. So that's about it with the.
What fluoride do you use? What fluoride do you use for that?
I'm using Profluoride by Waco.
Oh.
It comes in various tastes, and it's 0.4 ml in one packing. You have bubble gum, you have caramel. So I give the option to the child to select, and it adds on to your behavior management and acceptance of the same.
There's one last question. I think in one of the scenarios you had extracted 5-1, and I think there's another question which is coming, like if 6-1 needs zirconia, can we bond 6-1 and 6-1 zirconia to a cantilever on 5-1? I think one of the cases you had shown some Groper's modification. I think that looked like a better option, but I think if you can club up these two things and answer that question. The question was straight. If there is 5-1 to be extracted and 6-1 to be placed, can you place zirconia and do a cantilever? But my addition to that question is, I saw the Groper's which you had done without the acrylic, and it worked really well. So what would be your take on either a zirconia with a cantilever, or will you go for a Groper's, because one side you had Groper's and the other side you had this thing? So your opinion.
I feel zirconia with cantilever will be a lot of heroics. Okay. Secondly, when you want to cantilever another zirconium to your already existing zirconium, I'm not sure whether your solder material is going to help actually prepare the cantilevered unit to be cemented. So I have my doubts with that, but we can always give it a try.
You did in the Groper's, I think you had 2 zirconia on the other side, and then you had 2 crowns.
Yes, sir. So there was 5-1 and 6-1, 5-1 and 5-2. There were 2 separate crowns, 2 separate zirconium crowns.
Yeah. And in 6-1 and
6-2 were composite enamel shells that we fixed onto the metal framework.
Yeah. So instead of the zirconia, is it possible that we can use 4, like maybe cantilever might not be possible?
Instead of the composite, you are saying that can we put zirconium?
Yeah, that is my question.
Yes,
yeah, that was not my question.
That can be done. That can be done, and that I have done.
Which I added recently, just after seeing that, because I was wondering why you chose strip crown on one side and zirconia on the other side. Would that have been zirconia? Yes. This is my doubt.
We have done that, sir, and that's a better option when you consider aesthetics, because flushing a composite with the zirconium is very difficult. But composite on cantilever on the metal framework, yes, of course, that can always be done. But trust me, sir, when I did it over here, it was a lot of headache, a lot of trimming. And eventually, once the position is fixed, you cannot do anything with regards to the final position of your composite, that the zirconium that will go inside the mouth. The other thing, problem that I faced was I filled the interior surface with acrylic. So when the child came back after a year, there was no retention of the zirconium to the acrylic. So when I had to re-cement it, I used my glass ionomer and pushed it back on the acrylic pontics that were created because of the interior surface of your zirconium. So these were problems which I have faced with using zirconium. You can always do that if the parents are willing to pay, but I feel it's an overkill.
Yeah, yeah. But I could see a lot of work put in with all your patients. I've seen so much of your photographs and so many presentations. But today, again, only concerned to aesthetics and trying to do a gropus with the composite and trying to put some minimize the acrylic. I think it would have been a lot of work actually.
Right. It is a lot of work, in fact.
And as you were presenting, actually, me and Dr. Geeta Priya were discussing about this heated composites. Heard of heated composites, but what is your take on that? How did you how did you get into heated composites? Anything on why you think? Yeah.
So I got myself trained into the BioClear philosophy, sir. So I'm not sure whether you're aware of it, but these are like clear, transparent matrices. So for young permanent molars or your class 2 restorations or the class 4 that you saw, we've had good amount of results with the injection molding technique that is used in the BioClear philosophy. So they have specific matrices for the anteriors and they have specific matrices for the posteriors as well. Since this was a presentation restricted to the anteriors, I could not show the cases that we have done, but we've had fairly good amount of results for even the class 2 restorations that have been restored with heated composites. So in some cases where parents insist that they don't want the metal crown or the zirconium, but they still want an aesthetic option, that's where your heated composite is helping us.
I saw
that's how I got to know how to heat the composite, and then I applied into the strip crowns.
You applied that to strip crown. That was your
yes, yes,
knowledge converting into wisdom. Right? Okay. Yeah. Because I've seen, I've heard of this this thing, but I don't know what exactly about this BioClear system. But heated composite in primary teeth was something I wasn't sure about. So I wanted to know where you got that idea from and how you changed into that.
Yes.
Thank you so much, Abhishek, for sharing all your knowledge, all your ideas, and it was really good to see all the open small tidbit secrets, and that's exactly what we wanted.
That's how you wanted it, sir. So that's how I modified it yesterday only.
Okay, yeah. Okay. Thank you so much, and a small token of appreciation from our side, a certificate for you. Thank you so much, Abhishek. We're looking forward to.
Thank you, sir.
Thank you, Abhishek, for being a part of our CDU program and sharing all your secrets in Pedo.
Thank you, ma'am, for coordinating. Thank you.
Thank you. Now it's time for vote of thanks, and I take it a privilege to represent Team Pedo to deliver the vote of thanks. Right. Firstly, I would like to put it on record my sincere thanks to our beloved Vice Chairman and the management for the support. They've constantly supported us with every endeavor we have done over the last decade. So thank you so much. Secondly, I would like to thank our President and Secretary of ISPPD. We have tried to organize this event under the aegis of ISPPD, and thanks to Dr. Danu and Dr. Nikhil sir for giving us permission to organize this two-day event under the aegis of ISPPD. A guest of honor, Dr. Shivakumar sir, my teacher and mentor. Thank you, sir, for agreeing to be the guest of honor yesterday. Most importantly, the artisans, what we call them, the 6 eminent speakers, Dr. Neeraj Gubnani, Dr. Nikhil Marwa, Dr. Jeevarathan, Dr. Ganesh, Dr. Milan, and Dr. Abhishek. I think they shared all their open secrets. They gave us small tips, and I think they did justice to whatever was handed over to them. They took it as a real good responsibility. And I think we couldn't have expected to have a better finisher than Abhishek. And thank you, Abhishek. Not that just because you are here and the rest of the speakers are not there. I wanted it like that. And I think I told you that ahead of time that I would want you to finish. And thank you so much. I'm really happy that the choice of speakers and the order in which it was placed was also good. Thank you so much. Thanks to all the speakers for accepting our request and making this program a success. Sincere thanks to all the delegates, the clinicians, academicians, professors, teachers from Tamil Nadu state and all over the country. Special thanks to Pandit sir. I think he's always tried to come in and help me in whatever event I've organized. I think he was always there. And thank you so much, sir. My friend Dr. Prasad, professor from oral pathology, I think he's helping us with the technical aspects of organizing this event online. He's been sitting with us a couple of days with the YouTube and links and all that. Thank you, Dr. Prasad. Lastly, my team, the team Pedo, headed by Dr. Geeta Priya, my friend, right? I have no words for them. Whatever we wanted, they've always been there for us to organize an event of this gratitude. My sincere gratitude to all of them. Thanks to the Almighty for helping us and allowing us to organize such an event. Thank you so much. Thanks to everyone present here. Thanks to everyone who's been a part of this. Hope Team Pedo will come up with some more events in the near future, and all of you will be there to support these events. Thank you so much.
Cover about aesthetic restorations in non-permanent anteriors. So let's look at the role of BioClear in dental traumatology. Now,
the session will be open for another 5 minutes for you all to take up the pre and post test assessment.